everyone. This is Dr. Shamam, and today our topic of discussion will be very interesting and very fascinating for pathologists to see under the microscope. So, this is infections of the central nervous system. So, it's always cool when we see organisms under the microscope, and I personally get very fascinated and I enjoy that. Not good for patients, but like we being pathologists enjoy it. So, let's dive in. That's our topic today. So, this was basically my presentation at University of Washington during my observership rotation there in the neuropathology department. So this is gonna be a series of videos on different infections of the central nervous system, and what I would do is I'll make one infection in one video, and we'll discuss that in detail, and then proceeding forward. And I hope you liked it all, and let's dive in. So this is gonna be our second video, and today our discussion. So in this video we will discuss the whole infection, starting with the name of the infection, which will be discussed today. Then I would give an arbitrarily scenario of how that infection most commonly presents. And then we'll talk about the characteristic histological findings, then the IHC implications, and what are the findings seen on IHC. Then at the end of the video I'll talk about brief pathogenesis of how that infection occurs, and what is the pathogenesis of the disease, and the clinical presentation. Later on, if there are any complication of the infection, that would be discussed in end of the video. So let's dive in, and this is gonna be our second video in the series of infections of central nervous system, and the topic is progressive multifocal leukoencephalopathy. This is basically caused by the JC virus, so that is the virus of discussion today. So starting with the scenario, this is an old patient with end stage renal disease on dialysis. Just give me the pointer. So yeah, old patient, end stage renal disease on dialysis, presented with a 1 month history of neurological symptoms which are progressive, including ataxia, dysarthria, diplopia of unclear etiology. When examination was done, cerebellar ataxia was confirmed. CSF analysis were largely negative. JCV PCR, cryptococcal antigen, VZV testing, these were all negative. Epstein-Barr virus was like mildly elevated. Further additional testing showed that aspergillus antitoxoplasma antibodies were negative. Continuation of the scenario, the flow cytometry was performed, which showed no evidence of abnormal B lymphocytes. Serologic testings for syphilis and HIV were also negative. Then we did brain MRI. So brain MRI demonstrated patchy areas of enhancement, predominantly involving one side of the cerebellum, and the other side was not involved that much. No acute infarction, hemorrhage, or discrete mass lesion was identified. Patient then later was progressed to the stereotactic biopsy. Now, the interesting part starts. So, on histology, what we saw was that some areas of the brain were normal. We do see here in this picture the normal areas, adequately eosinophilic, adequate cellularity seen here. But compare this with this area of the biopsy, where you see clear difference. These are the pale areas, less eosinophilic, less cellular, and these are gonna be look like abnormal areas. Now, what we did was the next workup to see what is abnormal and to go on to the diagnosis. So let's be detective at this time. First stain was PS stain, and also called the LFP stain. So what they did was we did in the normal areas, the previous slide comparison, they show PS positive. This blue staining indicates that PS is positive here, and what it is interpreting it that myelin is present here. Okay, while comparing these less cellular pale areas, PS was negative, and we do see no blue staining here. That indicates that myelin is not present in these areas. Now the question came in mind that if myelin is not seen here, then what is the reason of not having myelin here? Now it can be two. Either axons are damaged, not producing myelin. okay? Or secondly, axons are there, but they are not producing myelin. It means that it's a demyelinating disorder, okay? So first was that axons are damaged, that's why they are unable to produce myelin. And second is that axons are there, they are normal, but the demyelination process is going on here, okay? Now how that trouble would be solved, we did neurofilament stain, and that is gonna be the game changer. So what neurofilament does is that it stains for the presence of axons. So you do see this brown staining, it indicates that neurofilament is positive, that means axons are present. And we do see in that abnormal area still neurofilament is present, brown stain is seen, and that means axons are present. So what we interpret here is the summary of the whole two stains we did is that in the abnormal areas myelin is absent as PS is negative, but axons are intact because neurofilament is positive, which suggests that it's a demyelination disorders. And now we'll focus on the viruses which cause demyelination, and the thing came in our mind was maybe it's JC virus. So what we did next was doing a specific stain for JC virus, which is SV40, that I'll show you later. Next we also see this eosinophilic, the H&E slide on which we see this oligodendrocyte with large nucleus and amphiphilic viral inclusions within it, and these virus would later be decided at which virus it is. So SV40, as I mentioned before, that was the next game changer. It highlighted and it just crystal cleared the whole scenario that see JC virus inclusions within the oligodendrocytes, and these brown dots are basically the viral inclusions within the oligodendrocyte. As I showed you before in the image, the oligodendrocyte with a large nucleus and those viral inclusions within it, that was basically JC virus. So SV40 confirmed our diagnosis. So this patient was having JC virus infection causing progressive multifocal leukoencephalopathy, result of all the neurological symptoms which the patient was having. So little bit overview on what's the pathogenesis of the disease, just to understand, because I believe it's important to understand the disease, then you would more master the pathological findings, and like clinical correlation is obviously important. So pathogenesis, so PML, it's caused by JC virus, I already mentioned before. It's normally latent within the kidneys, in the B cells of tonsil, and in some patients within the brain. But what happens, how this infection occurs? So normally it is latent, but if a patient is having any disorder by which his cell mediated immunity is impaired, then what happens that this virus is reactivated, and that is where the disease starts to occur. So it reactivates in the brain and in the peripheral tissues, see, and once it's reactivated, it gains access to the central nervous system, where it either lytically infect the oligodendroglial cells, and we do see viral inclusions within the oligodendroglial cells. I've shown you the histologic image before, that's characteristic for it. Or it non-lytically infects the astrocytes, and there we do see in that scenario very large bizarre shaped astrocytes with pleomorphic hyperchromatic nuclei. By hyperchromatic I mean excessive dark blue stain, and by pleomorphic it means that multiple shapes of the nuclei would be there. So this is basically for very beginners in pathology who maybe are not familiar with the terms. And bizarre is like not too good, not too normal, just abnormal looking shape. So it can also infect the neurons in either combination with the glial cells or by themselves. So this is how the infection occurs. Either oligodendroglial cells are affected, or astrocytes are affected, or glial cells are helping in the whole process, or maybe it can occur by themselves. So this is how the disease occurs. Now, moving on, that what would be the clinical presentation? So, as our scenario, a patient would present with neurologic deficits, focal, including dysarthria, limb weakness, visual disturbances, ataxia, personality changes, occasionally seizures. It progressed relentlessly over a few months, and it can result in increased neurologic impairment, dementia, and eventually death can occur. These are its complications. And what would be the treatment in this scenario? That you need to excuse me, treat the underlying cause, that what is basically causing the immunosuppression. If that is treated, then PML can lead to the remission stage. Here in this scenario, since it is end-stage renal disease, we need to work on its renal process, make the patient immunocompetent as much as we can. And AIDS is the common cause of it. So if AIDS is the cause, in that case, AIDS therapy, the heart therapy, highly active antiretroviral therapy, that would lead to the remission of disease. And what would be the complications of it, of the therapy, is reconstitution of immune system in treatment of AIDS, and it can occasionally cause an inflammatory response within the central nervous system, and in that case disease can be exacerbated. So this is also a good point to be kept in mind, that if the patient is having AIDS, we did therapy, that can lead to reconstitution of the immune system, and even it can cause exacerbation of the disease. So this is a whole summary of PML with an example of a scenario focusing on the histological findings. That's all for today. So thank you everyone for your attention and for your patience. I would like to specially thanks my attending Dr. Daniel A. Child. He gave me the opportunity and all the slides from his archive. That was amazing. And I also would like to thank Dr. Alex, Joyce, and Lucy. They were my fellows in neuropathology. Amazing people and very good friends of mine. So thanks to them. This was like a few memories. I really like this picture. It was a night view of whole Seattle from the viewpoint. So nice time spent there. So thank you everyone. I hope you guys liked the video. If you did, please like it and share it with your fellows, so other people get helped by the whole process, the whole purpose of making videos. And if you just do share your feedback in the comment section, particularly who liked them, who even don't like them, you can share that too. And with the seniors who are watching, please correct me out if I've said something wrong, and I'm open to feedback. And thank you so much once again. So see you guys in the next video. It will gonna be a next interesting infection with some nice slides. So yeah, see you. Goodbye.